Morning and or afternoon to everybody. We're going to give people just a few more minutes here to get themselves situated, get logged in. Today, what we're going to talk about is visceral pain, some of the things that might come along with that, as far as pain referrals, regional referrals, things of that sort of nature. So we'll talk about quite a bit about that. I have added a lot of that into the Google Doc that we've been kind of building up as we go through these processes. In the meantime, if anybody has any questions about the biomechanics stuff, I think that's what Dave said that he was going through last week. I know they can be pretty complex and relatively confusing at times. So if there's anything that you guys want to review real quick before we get into the visceral stuff, we can go ahead and do that.
Did you say that stuff was posted for today?
Hasn't been yet. Well, there's some
Oh,
of it
okay.
that's on there. I've still been adding things on as we kind of build up toward the actual course. Um, so there is some on the Google document that we have. There is some things on there on the PowerPoint that's associated with it. It's a really shortened version of it, and I can add that stuff into the PowerPoint later as we go as well, to make sure you guys have it ahead of time for the course. But no, there's still some things that I was putting in this week that are not on the current document that you have, but you'll get it all before the course comes up. Nothing about the biomechanics? Courtney, I'm not sure which document it is you're talking about. Are you talking about the Google Doc or are you talking about the PowerPoint?
So typically in the modules, we would have a Google Doc going for like module one and module two.
Mhm.
When you click under module three, on my end, I don't see any Google Doc. There's
Okay,
nothing up. It's like empty. Everything's from 2023.
interesting. When I was just on there this morning, and there was a link right to the Google Doc that I was adding stuff into. That's how I got into it. I'll have to double check. Sometimes the access stuff that we have as the instructors is a little different than what you guys are getting. So maybe I'm seeing something different, but I'll double check.
Yeah, I
Um,
was on it the last couple weeks and I thought, do we have a Google Doc like we've been doing? And there's been nothing. And I'm going to ask this week about it.
yeah,
Um, but it
yeah,
sounds
we've
like
been
there's a
putting it
little bit of
together as we
confusion from
go.
other. Yeah.
But like I said, and you'll see it. Like I'll screen share it here in a second. But sometimes the permissions that we have as the instructors is a little bit different than what you guys will get as the students. So I'll double check with Dave when we get a chance to check on that. But it should be, like I said, it should be getting posted up there as we go along. But well, I'll have to double check with that, and that's probably something I'll have to do in a little bit. Dave's I know he's got a thing on here today, but he's at a school thing for one of his kids, so we're kind of flying solo here for today.
Yeah, Eric, when we look at it, the only thing that's been posted for us to have access to is the respiration PowerPoint. And then there was
Okay.
one shortened PowerPoint that said biomechanics. But Dave said he was posting articles and other stuff, and we really haven't had access to see any of that.
Okay. Well, we'll get that fixed up. Like I said, we've been working through it as we go. Maybe that's why it's not posting. Maybe that's why it's not posting is because we're still adding things to it. But I did see it on there this morning. So, like I said, it's probably a permissions issue on the website, but that's easily enough. That's easy enough for us to fix as we go through. So I'll talk with Dave about it once we get through all this stuff. We'll make sure you guys have it all. And it's really these are more the kind of didactic things that we want to get out of the way ahead of the course. So if you're attending the Zoom sessions, you're getting just the same amount of information as what we would give you through there. I know it's easier to be able to look through it again and be able to kind of study that stuff and get a real good feel for it. And that's kind of why we wanted to go through it ahead of time anyway, so that we could kind of touch on it multiple times, so that when we get into the actual weekend intensive, things are a little more I don't want to say automatic, but things are a little clearer, and there's less kind of confusion that we have to spend time kind of going over. But like I said, I'll figure it out. We'll get it sorted and make sure you guys have access to it once we're kind of through with it. So with that in mind, let me see if I can pull up thing here. All right. You guys seeing the screen now? Hopefully.
Yes.
Yep. Okay, good. So this is the doc. And again, a lot of the stuff that we've been going through is coming straight off of this. Most of these things here from the anatomy presentation that I did 2 weeks ago is all directly straight out of the PowerPoint that's in there, the fundamentals PowerPoint. So again, hopefully we'll get all this stuff sorted out. But again, you guys will have access to all this stuff once we get that fixed. So today what we are talking about, like I said, is visceral symptoms. And we usually include most of this stuff in with the thoracic mechanism, the thoracic course, because most of the mechanisms of pain that we have that are associated with visceral symptoms are due to sympathetic discharge, right? So the sympathetic afferents that are associated with innervation of the viscera, whether it's the thoracic viscera or the abdominal viscera, or even portions of the pelvic viscera, especially in men. We'll talk a little more about that as we go along. Are associated with that sympathetic system, so that sympathetic outflow. So because there's such a great kind of conglomeration of those nerve fibers within the thoracic anatomy, this is really the best place for us to kind of go over these things. So some of the descriptors, and hopefully you guys know some of these, we'll talk kind of vaguely about them or kind of briefly about them, but most of these sorts of pains that we'll get when viscera is involved is this very vague, very diffuse, poorly localized, really kind of difficult to pinpoint as far as where it's coming from. Okay, and that's actually really important when we're looking at these sort of things, especially with the abdominal viscera. It gets a little more muddy when we deal with the thoracic viscera, so we're dealing with cardiac issues or lung issues just because the innervation is a little different, and a lot of the things that will affect the cardiac components or the lung components, including the pleura, produce a different type of pain because of the different type of sensory the nociceptors that are being stimulated with that stuff. So the other thing that I do like to mention is that most of this stuff is not affected by movement of the trunk or the limbs. Okay, so if a patient comes in and they say every time I turn my body to my right, looking out the rear view, looking out the rear of my car to back out of the driveway, it produces this sharp pain through my chest or into my back, or wrapping around the rib cage, something like that. That's a pretty clear indication that that pain is associated with some sort of mechanical motion, right? So that would tend to suggest a joint, some sort of ligament, maybe a muscle, maybe multiple of those different structures. That's a good thing for our purposes as physical therapists, because we want to be able to see a situation where we can reproduce these things with either movement or sustained positions, or other types of mechanical stresses, right? So inspiration, expiration, all these different things that move the structures of the trunk. If those are producing or reproducing the patient's pain that they're coming in complaining of, that's a good deal. That tells us that it's probably something that we'll be able to find, something that we'll be able to work on, diagnose, and find a specific mechanism by which we can kind of treat that sort of thing. This does have the idea that it's not affected by movement of the trunks or limbs. It has one very specific kind of exception to that rule. And we'll talk more about that as we get to kind of the lung components. Pleural irritation, because it actually attaches to the ribs, can have a mechanical pain, or at least it looks like a mechanical pain. So we'll talk a little bit more about that as we get down the presentation here a little bit further. But that's kind of the one major exception that we'll find. The other thing that will tend to be kind of a dead giveaway that we have that we're dealing with more of a visceral pain than a mechanical pain or somatic pain is that it can also be affected by other bodily functions. So somebody that has, an abdominal pain that starts to be reproduced after eating, 30 minutes, an hour, or something like that after ingesting food, we can obviously start looking at that as potentially some sort of digestive tract issue. Um, things like um, stress exertion, et cetera, things that might be associated more with cardiac things. These are other bodily functions that can actually increase the discomfort the patient is having. So it's more associated with that particular activity, with the function of the viscera itself, as opposed to the movement of the body, which is really more where we come in. And again, we've talked about this multiple times as we go along here. We're really just trying to, we don't have to specifically diagnose what's going on with a particular person. I don't need to go in and call a physician and say this person has a pleurisy or an atelectasis or something of that sort of nature. I don't have to be that specific. All I have to be able to tell them is this does not look like a mechanical pain. And I think this person needs more, um, medical testing to be done in order to figure out what's going on with this sort of thing. So hopefully we're going to get real in depth on some of these different things as far as how the pathoanatomy of these sort of things causes problems. But we don't really have to be that specific when we're in clinic. We just have to be able to look at somebody and say, like, this doesn't look right, doesn't present like something that's mechanical, so it doesn't present as something that's somatic, something that really falls under the umbrella of the physical realm that we should be working on. This looks more like it's a visceral issue. This looks more like it's a systemic issue. So we need to kind of move this person out of our realm here and get them into the position where they're looking at more medical examination to figure out things. Okay, so hopefully as we're going through this stuff, I always like to be more detailed than we necessarily have to be. Um, Tends to help me, I think, understand things a little bit better. So maybe you guys are a little bit different with it, but I do think it is good to go through all this stuff just to make sure that we have a very substantial understanding of what's going on. So the spinal cord essentially is one of the major issues that we have to kind of take into consideration. The reason I wanted to talk about this is just because of the organization of the nervous system in this region, right? So the biggest thing is talking about the autonomic, so that's the sympathetic, parasympathetic components, the pathways that are affected here that start to, create these sort of abnormal, these dull, aching, poorly localized pains that we get with visceral dysfunction. So, definition wise, it's obviously pain that originates from the internal organs. Kind of like we talked about, dull, diffused, poor, not easily localized. Somatic pain should be more sharp and well defined. We can obviously have aching, dull pain. That tends to be transmitted more by a particular type of nerve fiber, a C fiber, where we can have kind of the memory of pain that's associated with things. C fibers are more associated with the way things like segmental facilitation are produced. Kind of this constant slow stimulation of these C fibers just kind of bombards these regions of the spinal column, whether it's within the spinal cord itself, as it would be with say a cervical segmental issue, or if it's more of a peripheral nerve dysfunction where we're looking at it in the lumbar area, because we talked about specifically the spinal cord itself ends usually right around T12, maybe L1, depending on interpersonal variation. But again, those C fiber afferents, those are the things that tend to produce those facilitations. They give us more of this kind of dull, achy, burning type of sensation that can be associated with somatic pain that's not necessarily sharp and well defined. Okay, so we can have a little bit of both, but it does tend to kind of affect the type of nerve fiber that's being stimulated there. Okay. Most of these afferents, so afferents, I always look at this word because afferents and efferents, I don't know if you guys were like me when you were in PT school and you needed to make up mnemonics to remember these things. I always looked at the letter A. Well, that says that it should be going away from the spinal cord, but it's not. It's the opposite of that. So I've always kind of port rounded myself into remembering that sort of thing. But these incoming sensory signals, they travel alongside the autonomic system. So the sympathetic mechanism is really where most of these things kind of enter the spinal cord at various levels in the thorax, and that's where we get this reference of pain and how it kind of may vary where they feel these things across the trunk. Okay, so most of the time it's going to be within the thoracic mechanism, within the thoracic region. We can very much have that through the abdominal region as well, because most of the abdomen, the skin of the abdomen, is supplied by the thoracic levels. And in men in particular, we can also have groin or testicular pain that's associated with these things as well. Very specifically, there's a portion of the notochord during development that is associated with kind of the embryological beginnings of the testicles in males, right? So this sort of thing can present as testicular pain, and we have to definitely differentiate the idea between testicular pain and just simple groin pain. It does tend to be a very noticeable thing, and most male patients, when they come into the clinic, if this is one of the complaints they had, they will be very specific about it. They might be a little uncomfortable talking about it, but I've found just a simple line of questioning, is this groin pain or is this more um, testicular pain that you're dealing with? They'll kind of look around a little bit and kind of give you that definitive, like, no, it's definitely more testicular pain. And that instantaneously, if it's related to mechanical movement of the trunk, the area that you're going to look at is T12. That's the embryological origin of the testicular development in males. And so there's dysfunctions within that segment that can occur that can refer pain into that region for men. Okay, so not necessarily something that we have to automatically be like, oh, geez, well, this is not something that we should be looking at. You need to speak to a physician or a urologist or something of that nature. That is something that can also come from a mechanical problem. All right. And we'll talk more about kind of the distribution of pains through the trunk when we go through the thoracic scanning process during the class, during the weekend intensive. Um, what we're looking for when we are taking a patient through movements of the trunk is we're essentially looking for reproduction of pain within the trunk. That's why we'd be doing a thoracic scanning examination instead of a lumbar scanning examination, right? So if I'm moving my trunk, I'm doing trunk rotations or, kind of doing flexion movements, extension movements, etc., through the thorax. And again, we'll show you guys how to isolate these things. And it's reproducing pain in the legs. That's not a good sign. That tends to be a bad sign that we're dealing with something that's impeding the cord, impinging on the cord. So realistically, if we have lower extremity symptoms, we should be doing a lumbar scanning examination, not a thoracic scanning examination. So we're really looking at, the range of symptoms is somewhere here within the trunk, posterior chest wall, abdomen, or like I said, maybe into the groin. Those are really where we'd be looking at. We want to see what the thoracic spine is capable of doing. Okay, so as far as the innervation goes and the visceral innervation, there's a nice little chart here that I kind of put together just on some of these. There's other ones that I decided not to include, at least for the time being. But what we see is that these visceral afferents, they enter the spinal cord through the dorsal roots, and they should travel through those same spinal segments that associate with the skin and muscles. So it does create this kind of convergence. And from a name perspective, this viscerosomatic convergence is where we're looking at this kind of referred pain or this reference pain coming from the viscera. Okay, but the perception that the body is getting, that the cord is essentially misinterpreting here, is where it's coming from. So it might show us pain on areas of the body's surface, even though the pain is actually deeper, more into that visceral mechanism, right? So we have to be aware of that sort of stuff. And again, we should see this presenting more as these dull, achy, kind of poorly localized things as they come through. So As far as, kind of some of these references, we'll talk more about cardiac stuff as we get down a little lower here. T1 through T5, relatively speaking, I'm not utterly convinced that that's the case, mostly because of the sympathetic chain that's associated with this. Okay, and like I said, we'll talk more about that as we get a little bit lower. But what this should reference for us is we're going to get more chest pain, maybe some shoulder pain, arm. The arm stuff, again, is more associated with the sympathetic mechanism. Same with the jaw or the neck, throat area that we can get some of these referred pains from the heart. It kind of is noted here. Interscapular region, again, in between the shoulder blades is another common region of reference here that we would feel this, again, more superficially. Lungs, very similar, little touch lower, but mostly we're going to have something in the chest wall, maybe into the upper back. It would tend to be a little more unilateral with that. And again, there is a component of this that's going to be more mechanical, or at least have mechanical components of that that's associated with the pleura. Okay, so again, we'll talk about that a little bit more as we go down here. Stomach, this is a big one, mostly because of things like ulcerative colitis. And various other, well, I guess ulcerative colitis is obviously more in the colon, but because of more digestive issues is the way I should be saying this. These things drop down a little bit lower, so now we're looking at the epigastric area, so really the kind of near the xiphoid, that sort of region, maybe down as far as the umbilicus. These sort of things can also cause more diffuse pain into the mid-back as well. Okay, liver and gallbladder. The upper right quadrant of the abdomen is really going to be most of the time where you're going to feel these things. I've had multiple patients come into my clinic complaining of kind of this right upper quadrant pain, and that they think is one of their lower ribs. Um, but it's not at all associated with any of the movements that we would typically look at as far as moving their trunk, right? So inspiration, expiration, one of those two would tend to reproduce pain. Rotation of the trunk, even rotation of the head can do that sort of stuff. Loading of the trunk, so putting, upper extremity body weight bearing. Can actually irritate these things as we have to start to stabilize and kind of engage some of the abdominal musculature that attaches to the lower rib cage. But one of the things that they'll also tend to complain of is shoulder pain. Okay, and this is what's called Kerr's sign, and it's an irritation of the diaphragm due to either mechanical distension of the organ itself, so livers when they become pathological, if whether it's from something like a hepatitis or a cirrhosis, or any type of other hepatic infection, they tend to swell, right? And so the inflammation, whether it's from a trauma or whether it's from an infection, or the swelling, the actual mechanical distension of those tissues, irritates the diaphragm. And so the diaphragm being initially innervated by C3, C4, we get a reference into the same region of skin that's also supplied by C3 or C4, which is actually kind of right up here into that supraclavicular region. We can have a very similar thing associated with the spleen on the opposite side of the body, and I think there's actually another term for it other than Kerr's sign. I can't remember what the name of it is, but it's a different name. I've seen Kerr's sign be referred for both left or right shoulder. But I think there's another term, another naming term for the left side that's associated with splenic issues. But I can't remember off the top of my head. I'll add it in if I can remember it, or if I can look it up at some point. The kidneys, this is a big one right here, obviously. Lower flank, so we're looking at posteriorly on the flank and kind of working its way down toward the pelvis. It's very similar referral region to having discomfort from the quadratus lumborum or one of the atypical lower ribs, right? So the 11th or 12th rib. Tends to be referenced from T10 to about L1. Again, most of the skin that's innervated by that region is either going to be over the lower abdomen anteriorly, or over that lower flank posteriorly. Okay, so again, we're looking more toward kind of the spinal gutter medially and extending laterally to basically the edge of the iliac crest. is very common for reference from the kidneys. The small intestine and the colon, again, very common problems because of digestive issues, because of things like diverticulitis, because of things like ulcerative colitis. We can have reference into the umbilical region, so just around the umbilicus, maybe a touch lower down toward the pubic bone. And same thing with the colon. Again, this will tend to depend on what region of the colon is affected. I would say the most common is the descending colon on the left side. So it would tend to be more left-sided. But again, lower abdominal wall, maybe potentially into the groin as things get further down those structures. Okay. Questions so far on any of that? Nothing yet. Okay. We'll keep pushing along then. So right here, this is the way it was described to me as I was going through my certification process and my fellowship process, is the idea of sensory only collateral nerves. Okay, so what this is that the viscera, because we don't want to be affecting the viscera with movement of the trunk, right? If I bend forward, I don't want that to affect the function or any discomfort that might come from my liver, right? Or from the gallbladder or the stomach, right? We don't want to have movements of the trunk affecting reference of pain or pressure or any of these different things coming from the viscera. That kind of leads me into another little soapbox moment that I get into sometimes with this is the idea of osteopathic or chiropractic treatments treating liver dysfunction or treating, stomach issues or things of that sort of nature. The idea of sensory only collaterals means that if I'm treating the spinal column, I'm very unlikely to be treating the viscera, right? Because the only thing the viscera can do is refer out the sensory components that come with pain, right? So that's what these nerves are. It's one in every about 1,000 to 1,200 nerves that are going into the spinal canal through oh God, what's the word that I'm looking for? Lateral component that associates with the sympathetic chain is one of these sensorily only collaterals. Okay, and so those are the things that transmit this kind of vague sense of pain that's associated with where we might feel these discomforts coming from the viscera. Okay, so there are some that have some motor and autonomic things. These are mostly things that are associated with like peristalsis and whatnot in the digestive tract. But most of these things only carry afferent signals back to the spinal cord. Okay, and here's a few examples of those sort of things. The splanchnic nerves, these, basically carry from multiple of the multiple organs within the viscera. So the liver, the gallbladder, the stomach, etc. These all come from the splanchnic nerves. Cardiopulmonary nerves, these are more within the thoracic viscera. Again, same sort of idea. These are afferents, and we'll talk more about these specifically because these will become affected and potentially blunted due to microvascular issues that can be associated with things like diabetes. Okay, so we'll talk more about how that might affect the presentation of cardiac or even pulmonary issues if they were to potentially walk into your clinic. Esophageal and gastric branches of the vagus nerve. This is a bit of a different one because it tends to skip most of the spinal column and go straight to the brain stem, just because that's how the vagus nerve is oriented, right? But the convergence here may also give a very complex pain referral where things like the esophagus, we can get pain anywhere all the way up and down the throat, all the way down to the epigastric region, and even, things like interscapular pain or mid-back pain that can be associated with these. And again, that's basically just due to the effect of the vagal nerve also, kind of traversing without interacting with the spinal column itself. Okay. But again, these sensory only pathways, these are the mechanism by which we develop visceral pain. Okay. And then this is the reason why it's kind of poorly localized because there's just not that many of them. Okay. How does visceral pain present? I always look at this sort of stuff when I'm thinking about mechanical somatic pain. is the idea that, well, if I put pressure, right? So if I press on a tissue and that tissue has been damaged, that's going to hurt, right? We've all done that. We've all had bruises. We've all banged our shins against the coffee table, and anytime you lean against it again, it hurts, right? And that's the question: is that inflammatory pain? Is it ischemic pain? Is it more of a mechanical, like stretching type pain, or a distension type pain? Um, that does matter, right? Because if we're looking at it and we think, okay, well, this is more of an inflammatory pain, this is being transmitted much more rapidly by A delta nerve fibers. Um, and so these things present much more as a sharp, stabbing type of discomfort because it essentially needs to be transmitted faster because the threat to the tissue is more immediate, right? So if I turn on the stove and I put my hand on a hot stove and I burn my hand, that's a chemical pain. That's going to be transmitted by these A delta fibers that they're myelinated, they're smaller, they have a much faster conduction speed because my brain needs to receive the information that, hey, you're hurting yourself here. You need to move that hand, right? Versus if I put my hand on something and it kind of slowly I put a weight on top of my hand and it kind of slowly starts to compress the tissues of my hand, that's going to more slowly build up. It doesn't need to be as instantaneous because the immediate threat to that tissue isn't as severe as the chemical mechanism, right? Where something's actually being burned and tissue is being damaged immediately. So again, these sort of things are important, especially with viscera, because we need to know, is this tissue inflamed? Is there more of an ischemic response here? Again, that comes in more with things like cardiac issues, but we could also have it with things like an ischemic bowel, which would present with very sharp and very immediate pain in the abdomen, right? So again, these sort of things have to be noted. So the visceral afferents, the chemical stimuli tends to be things like bradykinins or prostaglandins. Again, this tends to result more from inflammatory issues, which suggests more substantial tissue damage. Mechanical stimulation, where we're looking at the tissue is just kind of distended. Maybe we've all had this sort of thing where we've eaten too much. Stomach feels distended. It feels uncomfortable. We have kind of this achy type of stomach ache pain. Pressure could also be from something growing within the abdomen, which would be more of a space occupier. Again, the body tends to adapt very well to these things until there's not enough room for them to adapt. And then all of a sudden, we start to develop more discomfort associated with those things. But again, chemical stimuli, again, more likely associated with an A delta fiber, more immediate, more sharp, and mechanical stimuli, more C fibers, slower, more vague, more of a achy, burning, discomfort type of thing. Okay. Again, we talked about dorsal horn synapses there. They go on to second order neurons, which is basically these interneurons, and we've talked about these things before because these are the things that will actually start to create segmental facilitations. If these second order neurons are stimulated too often, it will actually wind up some of the reflex arc mechanisms, and we can start to get associated symptoms into somatic structures like, the intercostals or maybe the abdominal musculature, things of that sort of nature, which can contribute to some of the referred pain. All right. Cardiac pain. All right. So just getting into some of the specifics of the more important ones here, at least the more, what would you call them? More urgent ones that would kind of pop up in the clinic. So cardiac pain, hopefully somebody's not walking into the office with an undiagnosed cardiac problem. Um, that'd be very bad, because essentially it probably means it's been going on for a while, and that can really cause major issues down the road, things like heart failure and whatnot. Um, but it can definitely happen. And again, I was talking briefly about some of the issues that people have with um, microvascular trauma and things of that sort of nature. So we'll talk more about that in a minute. But cardiac pain, some of the common descriptors. I think there's, God, I used to know this too, but there's 23, 26, something like that, 20 something different words that can be used to describe chest pain. And according to some of the literature I've read, each one of these things is diagnostically relevant. And again, it's describing chest pain, not just cardiac pain. So again, things like crushing or pressing or grabbing, these things are more likely to describe cardiac symptoms than they are, say rib issues, which would be more sharp, um, stabbing type of things. But some of these things will overlap. Some of these words will overlap. But again, it's oftentimes related to the idea that it feels like something's kind of compressing the chest. You hear these things like, oh, it feels like there's an elephant sitting on my chest. That's one of those descriptors that will tend to be more noted with the cardiac symptom. Definitely can radiate up the neck. So from the trunk up the neck and into the jaw, down the left, or it is possible to radiate down the right arm. And it doesn't necessarily have to be medial arm pain. So it doesn't have to be kind of that ulnar-sided discomfort that goes along with it. Tingling, paresthesias are one of the symptoms that is probably most commonly associated with upper extremity signs from a cardiac dysfunction, but it doesn't necessarily have to be. It can be a sharp shooting pain. It can even be a dull, achy, kind of a numb type of sensation. Okay, and then obviously we can have more of the paresthetic, prickling pins and needles types of things that's more associated with vascular dysfunction in general. Um, why is it possible to have these things go down the right arm and as opposed to the left? Well, there are conditions where some of these internal structures are abnormally placed. There's actually a condition, I forget the name of it, where all the abdominal organs and the thoracic viscera, they're actually all reversed. They're on the wrong side of the body. And so it's relatively rare, but it is possible and it can't be ruled out, especially if somebody comes into the office saying, yeah, I'm having shooting pain down my right arm. I didn't think too much of it because it's not my left side. Well, is it worse with going up and down stairs? Yeah, it is actually. And actually, it's worse when I ride my bike. It's worse when I, um, you know, lift weights. It's worse when I carry in groceries, things of this sort of nature. Like, that's still exertion based. Medial arm pain probably should be checked out, get an EKG done, make sure that there's, no other associated problems that come along with that. Why can it be someplace other than medial arm pain? Well, and you'll see this down here just a little bit below this. As we're talking about the sympathetic chain, the arm pain oftentimes is associated with where the sympathetic ganglion, the more substantial sympathetic ganglions rest. And so the major one that's at the CT junction is the stellate ganglion. And so that rests somewhere around C7, T1, depending on individual variations in that person that's presenting. Um, and so that would present, C7, C8, T1. That would be more of a medial arm distribution that we would get as a result of stimulation of that sympathetic ganglion. Well, we could have a patient that has an abnormal placement where it's up more at C5-6, C4-5, and that would give us more of a lateral arm pain or shoulder pain, something of that sort of nature. There's such a thing as a pre and post-fixed plexus, where the nerves of the spine, the actual nerve roots, either exit the spine at a lower level, which would be a post-fixed plexus, or at a higher level than it's supposed to. Again, relatively rare variations, but abnormalities are the norm, right? So it seems like a oxymoron to say something like abnormalities are the norm, but variations in human anatomy are very common. Whether it's one thing or a dozen different things, the person can function totally normally because the body knows how to deal with the alteration because it's always been that way, right? It's not a threat, right? So it doesn't reproduce pain. It doesn't cause any necessary dysfunction. Maybe it causes a complication because of its orientation at some point where, if I get a stenotic change in one of the cervical levels, maybe it affects something more in that particular region than what would be expected because of a pre or post fixed plexus. But again, it would still be causing some issues one way or the other because it's a stenosis, right? So those things do happen. But again, that tends to suggest that we can't rule out any significant arm symptoms that are associated with physical exertion. The next bullet point down there. If they're associated with physical exertion, if it's an upper extremity symptom, it needs to be checked out, plain and simple, because we just don't know what particular anatomic variation might be walking into the clinic. Okay, so we have to make sure that the physical exertion side of this is the key point and not where the reference is. Okay. Again, that was another one of those things that was kind of a um, aha type of moment for me when I was learning this stuff. So again, the association with the sympathetic system is really the biggest thing that I want you guys to take away with the cardiac stuff because of some of the other symptoms that it can show us. So things like um, sweating, clammy hands, nausea, anxiety, obviously elevated blood pressure and tachycardia are pretty common, but these are considered sympathetic symptoms. They are more common in females than they are in males, along with things like interscapular pain is a bit more common in females as opposed to the crushing chest pain. These are just statistical anomalies. I don't know that there's probably some anatomical pathophysiological mechanism for these sort of things, but statistically, it's more common in women. Um, but it also helps to explain some of the more distal symptoms that arise, right? So we were talking about this just a second ago, but as the ischemia within the heart muscle starts to begin, it'll affect the mid-thoracic sympathetic ganglion, which is somewhere around T4, T5. Should give us chest pain and or interscapular pain, okay? It starts to spread, typically going cranially, so going up the sympathetic ganglion, where it'll affect the next major one in the chain, which tends to be that stellate ganglion, which will tend to give us that medial arm pain typically. Okay. It continues to spread up. It's going to hit the next one, which is usually at C2-3, which will tend to produce either the lateral neck or maybe the jaw pain that's associated with these things, right? So again, I like knowing these little anatomical variances because it helps me understand the symptoms a little bit better that might present. And again, variations in presentation, very common, right? And so the idea of knowing the anatomy and knowing the pathophysiology associated with these things tends to be a good deal for us as we take into consideration some of these possibilities. This is the other thing that I was talking about here is the idea that microvasculature damage, most commonly associated with diabetic neuropathy, can affect the transmission of some of these nerves and some of the nociceptors that are associated with cardiac symptoms. Okay, so this is what's called a silent heart attack. Okay, so they may get things like some of the sympathetic symptoms, sweating, cold, clammy hands, nausea, dizziness, disorientation, and shortness of breath. These sort of things may come on, but they don't have the associated chest pain because these nociceptors and these small these small nerves and some of these microvascular things. And again, the microvasculature, when we lose that, it affects the nerves, those smaller nerves, right? And so that's what ends up affecting the transmission of these pain signals. Okay, so these things can feel blunted, meaning like, oh yeah, there's a little something here, but they, misrepresent it as um, heartburn, something of that sort of nature, or it's never perceived at all, right? So, and that's kind of the dangerous one, because these attacks can occur in succession. If it's not a very severe heart attack, or it's just something that's kind of affecting certain portions of the heart wall, they can come and they can be transient, just like a TIA in the brain, where it doesn't necessarily have to cause a major episode. The problem is as that sort of thing happens, and if it happens repetitively, we end up with major damage to the cardiac wall, right, to the muscle of the heart, and now we're looking at things like heart failure as part of the equation here. Okay, so that's a very significant problem that we have to be, very aware of um, if we're, you know, handling a patient, we put them on a treadmill, we put them on a bike, we have them doing exercises in clinic, et cetera, et cetera. And, you know, they're starting to get these sympathetic signs that go along with that, that we might just brush off as fatigue. Like, well, this patient's not in great shape. You know, it's not uncommon for them to start sweating. It's not uncommon for them to get short of breath. It's not uncommon for them to, you know, feel disoriented, right? And so it's one of those things we just have to be aware of. And again, dealing with something like diabetes, because it affects vasculature, heart issues are, you know, there it's a comorbidity that does raise risk rates, right? So we have to make sure that we're aware of that. All right. We are plugging right along. I love it. This is one of the other things that I wanted to talk about. I mentioned it previously, the idea of pleural pain, okay? Because pleural pain can produce pain with mechanical movement, okay? Because what it is the parietal pleura it's the outer portion of the pleural lining the chest wall. It actually attaches to the inside of the chest wall. So when we move, when we breathe, when we twist the trunk, we bend forward, we lean back over a foam roll, all these different things, it moves the chest wall, thus it moves that portion of the pleura. And as such, it can reproduce um, what seems like somatic pain. Okay, so different than the visceral pleura, which is the stuff that actually overlies the alveoli, the lung tissue. So it doesn't necessarily generate the same type of pain or with the same movement patterns, right? So dealing with this is tough because it's really difficult to differentiate one from the other. Um, but it is innervated by intercostal nerves. It'll supply not just the intercostal musculature, but also the pleura and the peripheral diaphragmatic pleura. Okay, so these are other kind of linings within the thoracic wall that will move with various movements of the trunk. Okay, the phrenic nerve is not as important as far as the reference of pain. Okay, but we can have these issues, whether it's a mechanical issue, the movement of the pleura, or a chemical stimuli, which again suggests more inflammation. Okay, that inflammation is either a pleuritis or a pleurisy. Um, can be due to any number of inflammatory problems, infections, things like pneumonia, even a pulmonary embolism, or things like autoimmune diseases like rheumatoid arthritis or lupus or ankylosing spondylitis. All these different things can also affect these regions. Part of the reason that we think um, the rib cage becomes so limited in some of these autoimmune conditions, because the autoimmune conditions, one of the major first signs of an autoimmune condition is rigidity of the chest wall. So lack of a spring within the chest wall, which is, relatively speaking, a very serious contraindication to thoracic manipulation. And we'll talk more about some of the safety tests that we'll do during our examination process of the thorax, because there's really four of them. I think I always outlined three major ones. They're more related to neurological associated conditions, so things that are affecting the spinal cord, the three major ones. But a rib spring test is really a fourth one that has to be done, because if we don't have proper elasticity of the chest wall, whether that's from, you know, lack of elasticity in the cartilage, a lack of movement in the joints, whether it's a lack of pliability of the bone itself, which might come from something like an osteopenia, etc., or if it's due to lack of elasticity of the lung tissue itself because of something like a COPD, we have to know those sort of things. And the best way we have of checking that is with the rib spring test. And again, we'll talk more about that as we get into the course itself. Um, Other triggering factors here: neoplastic metastases. These sort of things can definitely happen, and it's just a space occupying problem, right? These things invade, they get bigger and bigger, they put more mechanical pressure on the tissues around them. After a point of time, there's less ability to adapt to that changing pressure, Every week I get this iTunes thing. Good Lord. But again, it tends to create more of the mechanical pain than the inflammatory pain. Pneumothorax, well, this should be a pretty serious one that we might run into, but it's basically just pressure of air irritating the pleura. People tend to notice less of the pleural pain because they're too busy dealing with the fact that they can't breathe. But we can have scar tissue that's associated with chest tubes in order to relieve a pneumothorax, things of that sort of nature that can affect the pleura over long periods of time. And a pleurofusion is basically swelling within that space. This is one of those things that tends to be problematic because it will tend to cause a collapse of the lung if it gets significant enough. Certainly can affect movement of the alveoli and kind of the filling of those areas. So it can create what's called an atelectasis. An atelectasis is an abnormal filling of the lungs. And what we tend to see with that is we'll see this kind of twisting because one side of the lung or one portion of one of the lungs just won't expand properly. And so we get this kind of abnormal trunk motion that occurs with that. All right, so as far as a pleurisy goes, we're going to get very sharp stabbing pain, right? But it's associated with mechanical movements like taking a deep breath, coughing, sneezing, or bending or twisting, right? Because now these things are moving with the trunk. Okay, it can radiate. Usually it'll be up to the shoulder. It can shoot pain kind of around the trunk. So kind of wrapping from posterior to anterior or anterior to posterior, depending on where the inflammation is. But it does tend to localize to the chest wall, so it doesn't really have this penetrating pain that kind of shoots through the chest. It tends to go around the chest. All right, we talked a little bit about this already. The inflammatory mediators, the prostaglandins and bradykinins, will stimulate more A delta fibers in the pleura. That leads to these signals being shot straight to the spinal cord, and then the brain's cortex will have to interpret that. But what we get out of that is a conscious perception of pain in these various regions. So if that's associated with shooting around the chest or associated with just a region posteriorly or laterally or anteriorly, it'll all depend on where the inflammatory component is located, right? So if it's more here, kind of anterolateral, that's more of where we'll tend to feel that pain. Talked a little bit about atelectasis, but distinguishing between pleural pain and other chest pains like cardiac pain or musculoskeletal pain like, say, a costotransverse pain can be very difficult to do because they will be associated with various movements. Now, what I would like to think is that we will tend to have an isolated pain-producing movement with a pleurisy, right? So if I have a spot here, kind of more on the lateral portion of my trunk, where I have an inflammatory reaction that's affecting the pleura, that parietal pleura, it will tend to be only caused by breathing mechanisms, right? So if I cough, if I sneeze, if I take a deep breath in, but it won't be as consistently irritated by movements of the trunk itself, rotation, etc., because it's not associated with the joint region, right? So it's possible to still have some reference there again, and I wouldn't base my entire diagnosis on this, but if I have somebody walk into the clinic and they say, yeah, I have this pain here on, kind of under my arm on my chest wall, and I'm going through my thought process, when I think, well, this could be a rib issue, I think rib issue, the determination that I have is that rib issues should be irritated by inspiration and or expiration. Usually it's one or the other. Rotation of the trunk, so rotation of my body in one direction or another. Typically, it's going to be a unilateral directional thing. And movement of the head relative to the trunk. Okay, again, if I rotate my head, we talked about this a little bit with the anatomy component. If I rotate my head to the right, the rotation of my spinal column occurs all the way down through the thorax, right? So the thoracic spinal column is also rotating. So relatively speaking, we are going to have movement of the costotransverse joints associated with that. So if I have all three of those positive for reproduction of this person's pain, I'm pretty comfortable that this is a rib issue. If, however, somebody comes in and I can't reproduce this with rotation of the trunk or rotation of the head, but I can reproduce it with inspiration or expiration, I'm a little more concerned that this now leans more towards a visceral afferent issue, right? So more toward this pleuritic component. Okay, so if the clusters of things like that don't match up very well, then we have to start taking into consideration some of these other possibilities, even if we're dealing with more of a somatic pain. So again, clusters like this are very important to me, and I use them a lot, specifically in the thorax. I think the three major biomechanical lesions that we have, facet joint issues, rib issues, and then ring issues, RING issues, will each have its own cluster of components that will reproduce pain or be limited in motion or both. So if I start seeing somebody that doesn't have all three, then yeah, now I'm going to get a little more concerned with the potential for more of a mechanical yet viscerogenic pain production. Okay. It is possible to do some palpation for biomechanical problems. So if it's more of an intercostal thing, or if it's more of a um, costochondral issue, something like that, I'd be able to palpate that and reproduce the pain, right? Versus I'm not going to actually be able to touch the parietal pleura. It's going to be underneath all of the ribs. It's going to be underneath all of the intercostal musculature. So I'm not going to be able to affect that very well with palpation, but I can do some of these other somatic structures. Like I said, some of the intercostal musculature, costochondral joints, the interchondral joints, these sort of things. I can palpate those things, and in theory reproduce pain as a result of that palpation. Percussion, we're really just looking for more of a thud. This is more of a physician's test. Same with auscultation, which is just listening through a stethoscope for a rub or for a dullness with inspiration and expiration that might suggest that this pleura is not moving very well. Again, they're really probably some of the only methods from a physical examination perspective to differentiate, but they're not really taught by PTs. We don't teach them in this course. So again, we just have to be kind of conscientious of the idea that if this is more likely, if there is potential for this sort of issue, what could be causing that, right? And again, that goes back to some of these things here, right? Inflammation, which might suggest infection, maybe an autoimmune condition, neoplastic issues, pneumothorax, which should be relatively obvious if something like that's going on, and definitely shouldn't be something that's happening in your clinic, or some sort of pleural effusion. Same idea, shouldn't be happening in the clinic unless they have some other systemic condition coming in. So again, just wanted to make sure you guys were aware of the idea that there is a potential for somatic pain reference that occurs with a visceral mechanism here, and that's just this pleuritic pain. So that is really all I had to say about that stuff. Let's see here. All right. So any questions, concerns, anything you guys want to ask about any of that stuff? Again, like I said, I really go into a lot more detail than we really need in the clinic. Again, in most cases, it's probably very high 90 percentile pain percentage that if you have these issues, it's not going to be affected by movement of the trunk. It's going to be very dull, diffuse, poorly localized pain that might present. It's going to be associated more likely with some sort of systemic body operation, bodily function like eating, drinking, physical exertion, those sort of things. So the idea isn't to diagnose it specifically for us. The idea is to take the notion that this may not be a mechanical problem and find them the right examination process, which would probably be with a physician at that point. So if we don't have any other further questions, then we can kind of break for the day. We'll come back next week. We'll see what we're going to talk about next week, and we might move into either the CT junction or the TL junction. some of the anatomy and biomechanics of that sort of stuff, or we might look into respiration a little bit. Dave and I will talk a little bit about it and see which one we want to do, but I'll talk with him again about the Google Doc that we're putting together and some of the PowerPoint stuff. Make sure you guys have it. But if we don't have any other questions, then I think we're all set. All right. You guys have a good week. Talk next week.